Welcome to this series of educational modules titled Mechanical Circulatory Support, Bringing Clarity, the Why, When and Who. My name is Professor Simon Redwood and I'm an interventional cardiologist at St Thomas's Hospital in London, and I'll be introducing and chairing these sessions. The main purpose of this session is that it is well known that the balloon pump is the first choice for mechanical circulatory support for cardiologists throughout the world. However, their appropriate balloon pump therapy has been subject to very heavy debate. Importantly, there appears to be a dichotomy between the clinical trial results and real-world practice. And the purpose of this series is to present a review of the physiological principles behind mechanical circulatory support and discuss the dichotomy between trial results and real-world practice and how that should reflect on patient selection. So welcome to this module where I'm joined by my colleagues Divarka Pereira and Nico Pils, and we'll be discussing some cases which illustrate some of the points that we've made in the other two modules where we highlighted the importance of tailoring hemodynamic support strategies for the individual patient. So I'll just turn to Nico first to present the first case. Nico.
Simon, it is a pleasure to show this case, and it is a lady in whom several indications for IABP come together. It is a woman, 74 years old, who had anginal symptoms and dyspnea on exercise since a week or so. And a couple of hours before admission, the pain deteriorated. She was increasingly dyspnoic, had increasing chest pain, and when she presented in the hospital, she had a cold and clammy skin, signs of pulmonary congestion, hypotension, tachycardia, respiratory distress, and a rather low oxygen saturation. So the diagnosis at that moment was subacute anterior wall myocardial infarction with cardiogenic shock. This is the ECG showing already the Q waves over the anterior wall, but still persistent ST segment elevations. We brought her straight to the cath lab, and there we found this severe coronary artery disease. There was a subtotal stenosis in the right coronary artery, which was dominant, and a couple of tight lesions in the LAD, probably the culprits for the infarction. There was an echo performed in the cath lab showing a poor left ventricular function and also quite severe mitral valve regurgitation. What to do with the patient? At this stage, the diagnosis was anterior wall infarction with cardiogenic shock, persistent ischemia. She still had a lot of pain and ST elevations. She had severe multi-vessel disease and quite severe mitral valve regurgitation.
So she had some evidence of ischemia or infarction in the right coronary territory too, because there was a little bit of ST elevation in the inferior leads as well.
I think that because the subtotal lesion in the right coronary artery, autoregulation in that territory is exhausted. During the infarction, the territory of the right coronary artery needs to become hyperkinetic to compensate, and as a result it becomes secondary ischemic. So in fact in this patient you can say that both in the infarct artery but also in the contralateral part of the myocardium, autoregulation is exhausted.
Right. So she actually had several indications for hemodynamic support.
Yes, definitely.
Persistent ischemia, she had cardiogenic shock, and she had severe mitral regurgitation.
Also MI,
Why IABP in this case? And why not, say, for example, in
Well, especially because of the ischemia. Here, in this case, the main problem is the coronary perfusion. And this perfusion was exhausted in the right territory and in the left territory. And this is a typical patient in whom, by increasing diastolic pressure, you will improve coronary blood flow. We have seen that in the beautiful studies by Divarka, how blood flow in these patients is directly related to the diastolic perfusion pressure. And in this patient, you have in fact two in one. You are treating the right coronary artery by increasing the perfusion pressure. You will improve the oxygenation of the inferior wall. And at the same time, this is a patient who came in a rather late stage. So there is definitely some no reflow, microvascular dysfunction in the infarcted area in the anterior wall. And also there, a high diastolic perfusion pressure will probably be very good for the patient.
So Divarka, would you have chosen balloon pump?
I think so, because as you say, there are so many indications for it, the mitral regurgitation, the high jeopardy, and the clinical, the hemodynamic status.
Yeah.
I would have done the same thing.
Yeah.
Yeah.
And by a flow device, you would of course improve the cardiac output, but you would not treat as effectively the coronary hypoperfusion
So you put the balloon pump in
before
straight off.
doing the.
So if this patient was randomized to balloon pump in SHOCK 2...
No, she was not in the
but
study.
If the patient was randomized to SHOCK 2 trial and randomized to balloon pump, they would have done the angioplasty first.
Yes, but in this patient, I think that would not have been a very good idea, because this patient had an indication for this balloon pump already from the beginning on.
Sure.
We needed to do high-risk PCI, both in the right and in the left coronary artery. She had already that MI, so there were multiple reasons in this patient not to have any delay in giving her the balloon pump.
Sure. Okay, great. So then what happened?
And this is then the right coronary artery after the PCI, which has been fixed quite well.
And you got a lovely result there.
Yes, then we went to the LAD, and also there we placed 2 stents, one in the 2 lesions in the proximal part, one in the middle part. That all went very well. The patient was additionally treated by GP2B3A inhibitors. She had some inotropic support for 1 day. The IABP was continued for 24 hours. Now we are 2 years later. The patient is doing well. She has not any cardiac complaints, and the ejection fraction is very nice. Compared to what we have seen before, it is 53%.
And the mitral regurgitation?
It is still there, but mild to moderate.
Really?
Yeah.
Oh, that's interesting.
You could expect that because the left atrium was not very much enlarged. So part of the MI was the acute ischemia. It was not a chronic MI. And if you look at the effects of IABP in these patients, we have of course the augmentation of the coronary blood flow, which in this case was not only beneficial for the infarcted area, but especially also for the contralateral area with a subtotal stenosis. So we had the relief of the persisting ongoing ischemia. We also had left ventricular unloading because the left ventricular function at presentation was rather poor. And we had, in addition, the afterload reduction for the mitral regurgitation. Sure. So I think that all the good reasons to implant an IABP, to give it in a patient you like to tailor for this, well, this was the ideal tailoring, I think.
And just coming back to it, although we touched on it, could you use an impeller in this case?
You could have done it, and
would it have
definitely
done the same thing?
The patient would have been improved by that, but the impeller would not have had too much influence on the coronary perfusion.
Right.
So I think that if you are just talking about increasing cardiac output, you could have used an impeller as well. Maybe the impeller would even be more effective in increasing cardiac output. But in this patient, the real reason for the poor cardiac function was the myocardial ischemia. And by improving the myocardial ischemia, you are improving output also indirectly.
Sure.
But more importantly, you do salvage of myocardium, and that has a beneficial effect on the long term. You might expect at least.
As we were saying in module 1 with the ABC, I suppose here we decided that ischemia reduction was of paramount importance, and so this was the right device for that, I think.
Well, and of course because of the mechanical complication of mitral regurgitation.
Yeah.
Yeah. In fact, this patient had also some similarities in BCIS1 patients, high-risk PCI.
High jeopardy score. And
yes, and I think that one of the reasons why in the very long-term follow-up in BCIS1 you see a benefit of the IABP is the fact that you are really saving myocardium. And that is something which will not translate into better survival in the short term, but it will become apparent in the long term.
That's great. Thank you very much, Nika. So why don't we move on to the second case? And Devaka, I think you're going to present that case.
That's right. So I'd like to share with you a case of a 55-year-old lady who presented quite late after what turned out to be an anterior SC elevation MI. This lady had hypertension before, but no prior cardiac history. And so when she first developed pain, she put it down to indigestion, and it was nearly 24 hours later that she thought to call for help. In fact, when she presented, she was in cardiogenic shock. Her systolic blood pressure was around 90, and she had the beginnings of pulmonary edema. She was sufficiently unwell that we did an echocardiogram before taking her to the cath lab, which is not our routine practice unless we suspect something else is going on. And you'll see the echocardiogram here showing impairment of left ventricular function, but this obvious large ventricular septal defect. And I think this was quite useful information to have before we actually did the angiogram. You'll now see the angiogram showing a proximal LAD occlusion. And at this stage, we had a discussion with our cardiothoracic surgeons on call, and the feeling was that we ought to support her hemodynamically and to do what we can, in their words, for the LAD.
So do you think she had ongoing ischemia at that stage?
I think she did, although it was 24 hours from the first onset of pain, so it was difficult for us to know whether this was a completed infarction and whether her problems were because of the VSD, or whether there was a combination of ischemia and the mechanical issue that had arisen from infarction. So we assumed it was both.
So probably 3 potential indications for support.
Absolutely.
Cardiogenic shock, persistent ischemia, VSD.
And a mechanical complication. We felt that the eventual answer would have to be surgical because it was quite a large VSD. And so our treatment consisted of putting in a balloon pump up front before we did anything.
Sure.
And then restoring flow in the LAD, which, as you see, we did just with the aid of thrombus aspiration. There was no balloon dilatation or stent deployment, because again, we thought that the eventual solution would be a bypass graft and closure of that VSD. Now, this lady did very well hemodynamically with the balloon pump, and by the following morning, she had been taken off all inotropic support, and she was very stable on the balloon pump. In fact, so stable that our surgeons requested that we give her IABP support for a few days, and that surgery ought to be delayed by a few days if possible. Which they often do. We did this, and on day 6, our intensive care colleagues felt that she was well enough to have her intra-aortic balloon pump removed. And it wasn't until they started to wean it that they realized how dependent she was on the device, because she developed fairly florid pulmonary edema when the weaning process progressed.
Were they measuring pulmonary pressures or wedge pressures at that stage?
Well, they had PICO measurements,
Right.
and the pulmonary edema in this case was very obvious because there was a chest X-ray that showed a lot of alveolar shadowing. The balloon pump was restarted. She once again stabilized, and within 24 hours of that attempt at weaning, she successfully underwent surgery.
Wow, that's great.
So I think...
So another nice case where there were 3 indications for support. It was very clearly shown on, I think you said, day 6.
Day 6.
Despite her being extremely well, when they tried to wean her, she went straight back into pulmonary edema. So she's obviously dependent on the balloon pump.
She was.
And that was adequate enough to, at that stage, there was no, really the only indication was the VSD.
It was.
Keeping it in at that stage.
It was.
It wasn't ischemia, and it wasn't cardiogenic shock, although the VSD and the cardiogenic shock, of course, are very closely related.
That's right, and the only time she needed inotropes was when she first presented, even and then briefly on day 6 when she developed pulmonary edema, but really with the balloon pump we were able to keep her off inotropes.
And just coming back to my point I was making earlier, do you think there would be any role for a different strategy, a different hemodynamic support device?
In this case, I think this is the best device, to be honest, both in physiological terms and also because the way she behaved is proof of concept. So I would use this every time.
Any comments, Nico?
Yeah, it's nice to see, and in contrast to the indication of persistent ischemia after MI, where I just mentioned that only a short time of IABP will be sufficient. This is a typical case where you needed it for many days, because here the idea is especially the afterload reduction, which is paramount in this patient and which is needed as long as the ventricular septal defect exists.
Exactly.
I mean, I guess in theory you could use an impeller for those few days after, but that's putting in a much bigger device and one with potential
It is. and
much riskier device potentially for several days.
I think at present, this is not one of the recognized indications, a VSD, for an impeller.
Right.
Yeah.
Okay. Great. Well, should we go on to the third case then?
So the third case was also a very interesting case. This was a young gentleman of only a 49-year-old who once again presented to our cath lab quite late. And the delay in this case was because his initial presentation was to a hospital that didn't have a cardiac cath lab. He was assessed there, and with all of the transfer times and so on, several hours had elapsed by the time he arrived at our hospital. And this was a gentleman who had no prior history apart from some impaired glucose tolerance. When he arrived at our hospital, he was in pulmonary edema and showing the early signs of shock. His arterial oxygen saturations were just 80%, and although he was maintaining his blood pressure at 120/70, he was tachycardic, and we felt that this was incipient shock which would develop.
So now where we work, that wouldn't happen anymore because all the local hospitals we bypassed because of the primary angioplasty network. Is that how it works in?
We have the same system.
You have the same.
Yes, all patients who are suspected of acute MI are transported immediately to a PCI center.
Which is how it should be.
Yes, I mean, as you pointed out, this was a few years ago before the network had this practice in place, and it ought not to happen, but because of the delay,
I
said it did, and it sort of illustrates the point. So we then took him directly to the cath lab, and the angiogram, which you can see, showed that the LAD was occluded proximally, and the circumflex and right coronary artery were relatively unobstructed. And once again, I felt that we needed to support his circulation up front. So an IABP was inserted before any intervention was undertaken. There was a significant thrombus burden, and so we treated the patient with a 2B3A inhibitor, thrombus extraction.
And just briefly, what effect did the IABP have? Was he hemodynamically stable at this stage once the balloon pump was in?
There was a slight early reduction in his heart rate, but no real change in his blood pressure.
Right.
So he became less tachycardic, but I have to say there wasn't a dramatic, obvious change at the time. And as you see now, that although we did thrombus extraction and deployed a drug-eluting stent, we were only able to get TIMI2 flow in the artery, perhaps a sign that there had been distal embolization.
Sure.
And demonstrating why he was in cardiogenic shock. There was minimal resolution of his ST elevation on ECG as well.
So Nico, what are the perfect indications for a balloon pump?
I would think so.
Even before we realized that he would have slow reflow and microvascular obstruction, we had put the balloon pump in up front in this case.
Of course.
He was then transferred to our coronary care unit, and echocardiography showed that he really had very severe impairment of left ventricular function.
But it was single vessel disease, wasn't it? It was just
it was a
very large LAD.
It was a very large LAD, and yes, you're right. It's surprising that it was so depressed, his ejection fraction, because in fact the right coronary artery and circumflex appeared normal.
I guess we don't know, but maybe there was a second pathology going on as well. Maybe he had impaired LV function prior to the infarct for some other reason.
It's possible that we had no documented history or means of assessing this. He was managed on our coronary care unit with IABP support, but showed signs of deterioration in the first 24 hours. Urine output was tailing off, his lactate levels were rising, and we by now had to support him with a dobutamine infusion as well. And he was demonstrating signs of falling off the slope and becoming really unwell. So the next thing was to escalate therapy. We took him back to the cath lab and inserted an impeller device, We used a 2.5 litre device because that was what we were using at the time. We would now have a CP.
So just coming back to what you mentioned about, so in the module where you were discussing the different hemodynamic support strategies, inotropes were given, they're not going to improve tissue perfusion, and his lactate was already high, so potentially actually making things worse.
Yes, I think so. And I think what was important here was that he had a brief trial of inotropes to see whether that allowed him to be supported long enough to then start recovering. But as soon as we saw signs that this was not happening, that recovery wasn't obvious and occurring early, rather than adding in a further inotrope or going to higher rates of dobutamine infusion, we felt he needed more powerful mechanical support.
So Nico, what do you think? Would you have done the same? Started off with inotropes to see if they help?
Yeah, most likely we would have done that because it is the simplest thing to do. And if that wouldn't have been successful, we would also have taken this step or go straight to ECMO.
And do you think there's any role, if we're just talking about the inotropes briefly, is there any role for, say, levosimendan or something like that which may possibly improve tissue perfusion as opposed to something like dobutamine?
I think levosimendan would have been a good alternative to use because, as you say, you get all the benefits of increased cardiac output without the increased tissue resistance, and therefore you maximize organ perfusion. Dobutamine perhaps would have been better than epinephrine or norepinephrine,
of course, yeah.
But I don't think there's a right inotrope that would necessarily have prevented us from escalating his mechanical support.
Sure. Okay, so you put the impeller in.
We put the impeller in, and once again there was a period of stability for a couple of days, but those markers that we saw rising started to rise again. His urine output by now had tailed off dramatically, and we continued our policy of escalation, and the patient then had a biventricular surgical assist device implanted and was transferred to a transplant center where I'm happy to say he eventually did receive a heart transplant and is now alive and well.
Fantastic. That's a great case. So that's a very nice case of clear escalation from balloon pump, quick trial of inotropes, which clearly weren't going to work in retrospect, then impeller, then biventricular assist, and then ultimately a transplant.
Yes. I think it illustrates that these are technologies that we have at our disposal that aren't competing, and that it's just a matter of selecting the right device for the patient's physiology at the time. And this case illustrates that patient's physiology and clinical needs will vary during the course of their inpatient admission, and we just have to respond to the demands at the time.
Do you think there's anything, just looking back at that case, and I know it's very difficult to say, but going back to the time when he just had the balloon pump in, to predict the fact that he was not going to be supported just enough with that balloon pump and was going to need further support?
I suppose it's the discovery early on, a few hours later, that his blood pressure hadn't improved adequately. He was still tachycardic. He was still in shock, essentially. And I think to have waited any more than 24 hours to give him a trial of longer than 24 hours would have been a mistake.
Yeah, I agree. Any comments, Nico?
Well, it is a very nice case, and especially the last step, that is that the patient truly got transplanted, is of course very good to hear. In our country, we would have had the same sequence several times up to the demand for transplantation, but it would have been very unlikely that we would have found a heart and transplanted. Sadly enough.
Great. Yeah. So Nico and Devaka, thank you very much. I hope you've seen there we've illustrated many of the points that we made in the previous two modules of when hemodynamic support strategies are useful, and the fact that you have to really tailor these devices to the individual patient. And remember that these devices are not competing, they're complementary strategies. If you do need hemodynamic support, usually a balloon pump will be adequate. And in a small proportion of patients, you need to escalate up to perhaps an impeller or some form of further support, such as ECMO, and even in one case, a transplant. Thank you very much for listening.